due to the impact of COVID. So our presenters this afternoon are Professor Imelda Coyne. Imelda is a professor in children's nursing and co-director of the Trinity Research and Childhood Centre. She's a fellow of Trinity College Dublin and a fellow of the European Academy of Nursing Science. She's held the Alva Myrdal Visiting Professorship at Malmö University, Sweden, Manchester University and the Nuffield Council of Bioethics in the UK, and she's currently a visiting professor at the University of Lund, Sweden and the University of Malta. In 2017, Imelda led the consultation with young people aged 3 to 5 years to inform the Irish Government National Strategy, the first 5 early years. This afternoon, Imelda will also be joined by her team members and co-presenting is Dr. Sinead Pembroke. Sinead is a research fellow on the Promoting Adolescent Communication and Education, or the PACE study. Her research interests include qualitative research, grounded theory, adolescent health and chronic illnesses. We're also delighted to welcome Shauna Rogerson, who's a research assistant on the PACE study, and her main research interests include clinical health psychology and patient-centred care. So we're really looking forward to hearing your presentation this afternoon. If you're tweeting this afternoon, please use the hashtag Reimagining Child Health. You'll see it in the chat. And if you have any questions, please add those to the chat as well, and we'd be delighted to add them at the end of the session. So you can take it away. Thanks, and we're looking forward to this.
Thanks very much, Mary. And just hi, everyone. And on behalf of the team, I'd like to welcome you to our talk today. So Reimagining Healthcare for Children and Adolescents with Diabetes due to the impact of COVID. My name is Sinead Pembroke, and I'm just going to start the talk today. So not to state the obvious, but as we are all aware, COVID has had a huge impact on all aspects of our lives, not least in hospitals and providing outpatient services. So in this talk, we'll be looking at this impact through the lens of our study with adolescents with type 1 diabetes. So we'll be kind of looking at the research side of things and also the clinical side of things. So I'll be starting off today by talking to you about the study itself, and my colleague Shauna will follow talking about the impact of the study, of COVID on actually conducting the study. And my colleague Professor Coyne will be talking on the clinical side of things. So I guess just to start off with, in terms of giving a context of type 1 diabetes in Ireland especially, the incidence of type 1 diabetes has increased worldwide for several decades, and it's actually been shown to be highest in Irish adolescents, 10 to 14-year-olds. What we found, or research has found, is that the majority of adolescents do not reach the recommended blood glucose. And so this means that this is actually a very high risk period associated with poor glycemic control. It also, a lot of disengagement with healthcare occurs at this time, and increased risk of complications, which can unfortunately lead to mortality. So as a result of that, guidelines have emphasized that paediatric diabetes services do need to be patient-centered, that adolescents need to be empowered to manage their diabetes. And so therefore providers should promote self-management. Because as other studies have shown, many adolescents are inadequately prepared for that, especially when they transition to adult clinics. So that's where our study is kind of positioned in. There's a real need for youth-focused interventions that promote adolescents' active engagement and self-advocacy skills in healthcare encounters. So as the next slide will talk about, just introduce to you, is our study itself, which is called the PACE study. And PACE stands for Promoting Adolescents Communication and Engagement Study. So the aim of our study is to develop and evaluate an intervention to improve youth question asking and provide education during paediatric diabetes visits. So there are three stages to this research. The first phase was focus groups and one-to-one interviews with young people aged 11 to 17, their parents and healthcare providers. And what we wanted to do was to determine the content for an educational video and question prompt list. You know, and then the second phase was to actually design this educational video and question prompt list so that they can use these during their visits. And the final phase then is to conduct a pilot randomized controlled trial, so as to evaluate the effectiveness of this intervention in adolescent diabetes care. So just to go into a bit more detail there in the next slide. What we did in phase one, it was a gathering information phase. So what we did was qualitative interviews and focus groups. We gave them a choice. So what we got then at that phase was 13 interviews with adolescents, 14 with parents, and 7 with healthcare providers, a mixture of nurses and consultants. And so, as I said before, we wanted to get their views of clinic encounters for adolescents, and this was based in 2 clinics in Dublin. So we wanted at this phase to identify facilitators and barriers to adolescents' participation during clinic visits, to identify content preference for the intervention itself. So the second phase, then we designed and developed it, and this involved a youth advisory group. So this study was adolescent-led, and that was really important to this study, you know, because we really value and see the value in actually including adolescents throughout the whole study. So this youth advisory group were instrumental in this, and we also had a parent advisory group, and there were 5 in each, a mixture of boys and girls. So the video was developed around key themes, and we also developed questions in the question prompt list with their guidance and their feedback. And then the last phase, which is so I should just say, actually, to just preempt, the phase 1 and phase 2 are actually complete, and thankfully we completed them before COVID. So phase 3 actually started in October of 2019. And so that's the phase that we'll be talking about now in more detail, because it is what we've been doing throughout this time throughout COVID. So the sample size that we have is 99, with 49 in intervention and 50 in control. So the primary outcome we are looking at here is level of clinic engagement, and that's measured by an audio recording of the doctor's consultation. And then the secondary outcomes are provider education. Again, that's measured by the audio recording of doctor's consultation. Their HbA1c, so that's we take that from from the nurses when they've measured it. Self-efficacy, which is measured by a survey that we administer, and self-management behavior, which is measured also by that same survey. So if we go to the next slide, what I want to show to you is the impact that COVID has had in actually conducting the study itself, which, as I've said before, Sean is going to talk in more detail about. But if we look at these charts here, so the first one relates to our plan. So as anyone who's involved in research would know, we have to come up with these plans to say like what we're going to do during the whole funding period. So in 2019, we had planned, that was our plan. We had planned to have recruited 140 adolescents for the study, and we had planned to do it in this time frame, as you see. So we have to follow them at 3 time points. So we plan to have them all recruited by October 2020, and then we planned to have them all the follow-ups, so follow-up 2 and 3, done by around April to June 2021. And as you can see from the second chart there, COVID really put a spanner to the works, or tried to anyway, but we have persevered and that's what we're going to be talking about. So as a result, we've recruited 99 young people, adolescents, and it's also impacted there, as you see on the chart, that we've had to extend timelines. And the yellow boxes indicate where we've actually had the, where we couldn't enter the actual hospitals because of the pause in, because of COVID, because of the level 5 restrictions, etc. So as you can see, it's brought out our study out to July, September 2021. And I should just say that, we're supposed to be finished up by December 2021. So it has had an impact on our ability to, we've had to really be flexible and we've had to really adjust things. So just to go on to the next slide, just to give you an indication of just what of our actual demographics of who we've actually managed to recruit. In terms of gender, we have 52% are female and 48% male, so around half and half there. In terms of age, the mean age is 13, so we were recruiting actually between 11 to 16-year-olds, even though it says 17 there, because in some clinics they do transition or start to transition at 16. So their mean diagnosis is 6 years, and the length at the clinic is 6 years. In terms of ethnicity, so the majority of our sample is they identify as white, and then we also have, in terms of where they are based, about 46% in Dublin and 53% outside of Dublin. So that's in, counties across Ireland. And in terms of the treatment demographics there, we have 58% on pumps and 42% on injection therapy. So it does give you just an indication of where we're at, of our sample demographics. So now I'm going to pass on to my colleague Shauna, who's going to talk in more detail about our difficulties and our challenges of conducting the research.
Thanks, Sinead, and thanks, Mary, for the lovely introduction. So as Sinead mentioned, I'm just going to talk briefly about our RCT and conducting that during COVID. So government restrictions understandably have posed various challenges on conducting research. And here we have just a roadmap from March 2020 up till now. So following the first cases of COVID in Ireland, we went into a national lockdown, and that meant that we had to pause our data collection. And then as we went on, as restrictions started to ease and numbers started to reduce, we were able to recommence data collection in both clinics by July 2020. And at that point, both clinics were operating at half capacity. So moving on to October, when we went back into a level 5 lockdown, research was then deemed an essential service, unlike back in March, and we were able to go back in at the discretion of the department within both hospitals that we were conducting research in. So we continued with our data collection, and coming up to the end of December, when we entered our third level 5 lockdown, we had to pause our data collection just to reduce footfall within the hospitals. Coming up to March, through communication with the healthcare providers, we were able to recommence data collection. We had to make a decision to stop recruitment, and this was because we follow participants up over 3 time points, and with the hospitals operating at half capacity and rotating from virtual to face-to-face appointments, it just wouldn't be possible to follow new recruits up. So now where we're at in April 2021, we are following up with our returnees for their second and third visits. That there's been a lack of consistency across the level 5 restrictions in relation to guidelines on conducting research. And I suppose that's due to the evolving nature of the pandemic. So that's our roadmap. And moving on, I'm just going to chat about how we conduct our randomised control trial. So Sinead kind of went through that briefly already. So we had been recruiting young people with type 1 diabetes from the age of 11 right up to 17. And once they were recruited, they would be randomly allocated to either the education the intervention group, which involved the educational video and the question prompt list, or the control group. And I suppose how that changed during COVID was that we had to, first of all, develop a health and safety protocol for conducting face-to-face appointments, which was then approved by the clinics and allowed us in July, as I mentioned, to go back in. And following this, we did have to develop a new protocol for the RCT and adjust that as needed. So mainly, the first issue that we noticed was there was less waiting time in the clinic. So previously, prior to COVID, the young people would be waiting long periods of time in between seeing nurses, consultants and other healthcare professionals, and with them reducing capacity, they were being seen more quickly, which meant that we had less time for conducting the research, and this was especially relevant for the intervention group. So what we decided then with the data managers in the clinic is that we would send out pre-clinic letters. So this meant that we were able to send out letters to potential participants who could then be recruited over the phone. And even if they weren't recruited over the phone, but they were interested in taking part in the research, it just meant that they had knowledge about the research and they were aware that there was research going on within the clinic. So that was really helpful. We also put the survey, which looked at the demographic information and the other variables that Sinead mentioned. We put that on Qualtrics and we were able to send that out to new recruits who were recruited over the phone. And then also with people returning for their second and third visit, we sent those pre-clinic letters out just to make them aware that they would be coming back for their second visit. We sent a paper survey with the letter so that they could be completed at home and brought into the clinic. And we also sent the link to the educational video over the pre-clinic letters. So with the recruiting, we made sure to do the intervention for the first time all face-to-face. So the first visit was done all face-to-face in terms of the educational video, the question prompt list and everything else. And then with their second and third visits, we were able to reduce the time face-to-face by doing out the video and the survey. So moving on to just some of the challenges around that. So on the left side, you can see some of our pre-COVID challenges. So there were some people who would come in presenting with low or high blood sugars, and understandably, this did lower their engagement or concentration, or maybe, you know, they were a bit fatigued coming in, and that did impact on the research. Also, this can be a difficult age demographic in general to engage in research. So that was a consistent challenge. The waiting time pre-COVID, as I mentioned, was quite long. So this often, you know, meant that we would administer the intervention, and maybe the young person would then be waiting a significant period of time before they actually saw the consultant. And then also just the general worries around self-management and getting HbA1cs taken. I actually joined the team during COVID, so I thought this was a COVID issue, but I was informed this has been a consistent challenge that we have faced throughout the whole study. So moving on then to our challenges during COVID. As I mentioned before, the hospital clinics have moved from full to half capacity, and they are rotating between face-to-face and virtual appointments. So we were advised to gain ethical approval to be allowed to record virtual appointments, and this was approved but later declined by the healthcare professionals for a number of reasons, and the main one being that oftentimes the young person might not be present in the virtual appointment. There is interesting research that might suggest a decrease in patient engagement outside of their face-to-face visits. So I think that definitely requires further research as time goes on. And this is something that obviously we will need to address when we are reporting our findings, the fact that we did miss those virtual clinics. That also meant that there was a kind of varied time period between the second and third follow-ups. So in general, the average cycle of being seen face-to-face was about 16 weeks, 16 to 21 weeks, but sometimes that could have been more. So there was kind of an inconsistent time period between the second and third appointments. Also, less waiting time in clinic, which I already kind of mentioned, and the fact that we were only allowed to have one researcher in each clinic meant that while we were recruiting and following up, it was difficult to kind of juggle with just coming in and having to administer the intervention while also trying to recruit new participants. So that understandably decreased our overall engagement and the number of people that we did recruit in the end. Lastly, and kind of more so towards the beginning of the pandemic, there was a slight anxiety around interacting with people and strangers in the clinic. So we did try to address that through the health and safety protocol and made efforts to kind of do that in plain sight. So just the general things like wiping down surfaces, the tablet, wiping pens down, and stuff like that. So moving on to how we overcame those challenges in the next slide, there has been some research done already around conducting studies during COVID-19, and mainly these have been clinical trials, but a lot of the themes still apply. So you can see here, Sheely and colleagues spoke about the themes of leadership, effective communication, utilising technological supports, engaging with regulatory bodies, maintaining participant engagement, and adapting ethics as needed. And I suppose for us, the main things were, effective communication, being creative with our approaches and being flexible. So, we were constantly adjusting things to kind of fit the new challenges that came up. And as mentioned earlier, it's an ever-evolving situation. I think the main goal for everyone was to minimize risk and kind of decrease any worries of sacrificing good quality clinical care. So we maintain this kind of communication through meeting regularly with the research team and also with the healthcare providers in the clinics. And we also found assistance from the data managers within the clinics to be hugely helpful because of how we adapted to the time, the less waiting time with using the pre-clinic letters. So that is how we try to overcome these challenges. It's an ongoing process. And that concludes my part of the presentation. I'm just going to hand you over to Imelda, who's going to chat a bit more about how things are changing as a result of COVID.
Thank you very much, Shauna, and thank you, Mary, for the introduction, and Sinead for starting us off. So as both Sinead and Shauna have showed, the COVID has had a huge impact on research and on clinical practice. And a lot of the papers published in this area have emphasised how the COVID pandemic forced healthcare teams to look for alternative approaches to manage a great number of children with diabetes. So a lot of clinics, and I'm not talking about clinics just in Ireland, I'm talking about internationally, they have moved to a mix of virtual and face-to-face clinics. There's been a combination of different technology used, from video consultations to email, to texting, to teleconferencing, and to telephone calls. I think most of the virtual consultations done in the two clinics we're involved in were mainly telephone calls. The term that's often used is telemedicine, but I know another preferred term is e-health, which kind of includes nursing and all other professionals who are involved in the multidisciplinary team. But what they say is, and most of the papers in this area conclude that, you know, e-health offers a critically important way to improve access, efficacy, efficiency, and cost effectiveness of healthcare for people with diabetes. So most seem to be in agreement that this is the way forward. But if we look at the advantages, and these are advantages that have been reported by people researching in the area of diabetes, and what they say is that, you know, it allows closer interactions with your patients because you can contact them regularly through technology, and you can empower them to take control of their condition. That you can manage a greater number of children in rural and urban locations because nobody has to travel. So if people were coming long distances, this really facilitates them. They also say it allows healthcare professionals to give a greater amount of support just in time. And that's linked to uploading of the data on blood glucose and various other measures that occur, like continuous blood glucose monitoring, etc. The data that can be provided online. And so doctors can intervene and give greater amount of support just in time. It's also seen as saving time for healthcare professionals and families because they don't have to travel, they don't have to wait in the clinics. And I think, as Shauna mentioned, you know, there is a long waiting time often in clinics. I mean, often clinics start quite promptly, but the waiting gets longer and longer. And children have reported that they find it difficult, and the parents as well. So it's seen as a big advantage if you can do a virtual consultation, because you can meet with the child and family, and it's a lot of time saved for everybody. Both Renard and Igeti et al., recent papers published, claim that there was no diabetic ketoacidosis in spite of the frequent higher insulin needs, so that there was no critical incidents through these virtual clinics. Chowdhury et al. Said that, well, you know, because we had this evolution of diabetes technology, closed loop system, continuous blood glucose monitoring, you know, insulin pumps, etc., that there's a huge variety of tools now available for monitoring. So it's easy to move to to kind of virtual clinics because you have all this monitoring equipment. And the last point is that, you know, it's easy to share this data because it can be uploaded, it can be cloud-based, and it can be accessed quite readily. So there seems to be, especially from the ICEPAD, which is the International Society for Paediatric Adolescent Diabetes, is that, this is the way forward, is virtual clinics. But there are challenges, and these are the challenges that have been raised. And I think what Sinead was mentioning earlier is that, the focus of our study is to promote adolescents' engagement in clinic encounters. So one of the problems with the virtual clinics is that the adolescent is actually not there for the meeting with the doctor or the healthcare professional. So the interaction is mainly with the parents. That you also will get patient disengagement and loss to follow-up, which occurs already, but that it could be worsened by these virtual clinics because they're just not present for the consultation, or they decide they just don't want to interact with the doctor at the set time. Camret et al. Found that there was a deterioration in blood glucose control, but this research needs to be handled with caution because there's a lot of papers which say that there was no deterioration in blood glucose control among children during the COVID pandemic. But this was the only paper that I could find which said that there was some deterioration in blood glucose control. Mainly because the children were at home, they weren't getting enough exercise, and eating food intake wasn't as controlled. Another challenge is the lack of healthcare professional skills in virtual meetings, and especially new junior healthcare professionals might struggle to actually do a comprehensive consultation virtually. Another issue raised by Castle et al. Was problems with downloading data from the device, that often parents or children might lack technical skills and the equipment to do that. Others, that they would experience slow internet limited internet access or slow speed. So it's difficult for those to have a virtual consultation. Castle et al. Said that seeing new patients virtually is not ideal because you really need to meet with them, see how they look, and assess them in person. And Norgard raised that as well. You can't do a formal physical examination virtually. There's also the challenge of that in some areas, and this is particularly internationally in not so well-developed countries, is that there's a lack of equipment, and also probably in some developed countries that, like in the sense that not every child has CBG, continuous blood glucose monitoring equipment, or insulin pumps. They're still testing with strips and injecting. So there's not everybody has a wearable device to monitor the blood glucose and do the continuous glucose monitoring. And the last point is that not everybody has the technology to be able to facilitate at home. And we saw this with the COVID pandemic generally, that some houses don't have a smartphone or a tablet or Wi-Fi, or they might, some organizations don't have online patient portals, and there is concerns around GDPR because with the very stringent requirements of GDPR, data sharing has to be done very safely without any danger of being hacked or also of being manipulated. And another point that somebody raised was that, these devices that have really evolved in diabetes care, they're seen as a brilliant way forward, but sometimes these devices might malfunction, or that the data recorded might not be as accurate, particularly with blood glucose monitoring or continuous glucose monitoring. Sometimes there's a lot of difficulties around wearing those devices, And so it's as somebody said, is it your spy or is it a friend? Because children can dislike having to wear it all the time and having all that data, and it reminds them that they have the condition. So there are some good studies in that area around the challenges with CGM, and that just because we have the technology doesn't mean that it's going to be widely accepted by all children and adolescents. What I thought was interesting when you think about, like, where do we go from here with this COVID pandemic and virtual clinics, that many of the studies done in this area have been done with people with type 1 diabetes, but often the sample didn't include adolescents or children. So there could be a lot of assumptions there that that it is the way forward, that it is the best way forward, because we really need to know from children how they feel about virtual consultations. But there is the point that some people have said, which is that, when we're trying to promote adolescents' engagement in clinic encounters, and they don't like going and they don't like having to wait a long time, and sometimes they're not very vocal, that maybe if they had a face-to-face virtual meeting with their doctor and could do that over a period of time, they could build up that relationships where they feel more empowered. They feel like, I'm the one being talked to. Maybe if the parent is sitting beside them, but the consultation is very much with the adolescent, with the parent beside them or the parent absent and then joining later. But a relationship could be built up over time, and maybe that might overcome the problem that which has been said by parents in our study, which is sometimes they have to kind of think of bribes to get their young person to the clinic because they often don't like going. And if their appointment is during the school time, they don't like missing school, and they don't like having to take a whole day out of their schedule if the clinics are running slow or running late. So there's pros and cons, but definitely one of the challenges is with virtual clinics being done only with the parents, because then the adolescent's voice is totally unheard. So if we think ahead of reimagining diabetes care, I think the opinion is that it should be like hybrid care, which is that it's a blend of virtual and face-to-face. Now, most would say that the evolution of the diabetes technology can help improve diabetes control, reduce hypoglycemia, and improve quality of life. And that telehealth combined with this diabetes technology can promote patient empowerment through the shift in responsibility, with more focus on providing patient education and supporting decision-making. And that you can do more, you can affect health behavior in a more significant way through digital interventions, because adolescents and children are growing up and they're seen as digital natives, and they are well used to using digital technology. So the argument is, if you have a blend of virtual and face-to-face, it allows more time for maybe doing more education, goal setting, and self-monitoring through digital interventions, and parental involvement, of course. So this model of care delivery has the potential to improve clinic attendance, social support, and patient-reported satisfaction. But there are a certain amount of people, or a certain amount of the research in this area, which says that we could easily move to full technology, whilst others are saying a hybrid would be the best way forward. And I would be suggesting that hybrid might be a way forward, provided the child is part of the consultation. So we have an increase in diabetes worldwide, and this could be seen as time saving. And diabetes care will be more and more dealt with in the primary care sector. So have we got a utopian or dystopian future where we have children that interact with robots rather than healthcare professionals, or that we have robots who completely take over, artificial intelligence replying to patients' concerns? Who knows what the future will hold? So to end our talk today, I'd like to thank our steering group, our funders, the National Children's Research Centre in Crumlin, Dublin, Ireland, and also all the staff, the doctors and nurses, and the data managers, Eric and Mona in particular, for supporting this study. And it's still continuing. So thank you all, and thanks to the team and the Youth Advisory Group and the Parent Advisory Group.
Great. That was absolutely fantastic. Thanks a million to everybody for their presentations. I was going to see quite a few questions coming through here, so we'll get started with those. So the first one that I can see here, and thanks a million, Rachel, is that she's interested to hear about the challenges of virtual clinics. I'm wondering if there's any advice or protocol to guide the virtual clinic process. So I'm not sure if any of the presenters are aware of that, or what have they come across in the course of conducting this study?
Do you want to answer that, Sinead?
Yes, I'll try anyway. I can say that I haven't encountered any protocols, as I said, because we weren't really involved in the virtual calls, unfortunately. What I can say as advice in my own perspective, as we were talking about, is to ensure that there is a time set, as if they were going for their face-to-face clinic, so as to ensure that the adolescent is there, that the adolescent has to be there, and ensure that the phone call happens around that time. I mean, I'm not saying exactly at 10 a.m., you know, they can take it, you know, into consideration that they might have a little waiting time, but that the adolescent is there the same as they would be for a face-to-face appointment. That would be my advice on that. I guess on another note, when it comes to in terms of what you use, you know, not everyone may have access to you know, an iPad, etc., you know, and that can complicate things. So you know, it is about establishing then as well what means, what method are you going to use in the telehealth? Is it the phone, or is it are you going to try and use iPads? But that's really all I can say on that. There are, I think, the health professionals who have been using telehealth will probably be in a better position than myself. But
yeah, I suppose that leads on to one of the next questions. Thanks for that, Sinead. You know, there's been a huge amount of challenges, and we can see a massive transition in how we deliver healthcare services during this COVID pandemic. What was the biggest challenge, or how did you overcome the challenges that you came across during this because of COVID?
So how did we overcome the challenges? So basically, a lot of communication. Communication was key. So, you know, I had to have, and I'm going to say it now, I really am so appreciative of both teams from both hospitals. It was thanks to them that we got through and I think we did overcome the challenges. I mean, it's still ongoing, but it is thanks to the communication. So we did have meetings. So say before the actual, so when we had the first lockdown, we had meetings then when things were beginning to open up, just before that, when we knew we were keeping an eye on things. That's what I mean by the communication. We were keeping an eye on what was going on there on the ground when they thought we might be allowed back in. And then we had actual meetings with the team. That was really important and instrumental. And that's what we carried on doing throughout. And that's how we came up with the protocol, for example, on how to conduct the research, you know, in a safe way, and throughout the COVID period. So yeah, communication was key, and really staying attuned to what was going on, because as I said, it wasn't just knowing what the announcements were going to be, but also what position the hospitals were going to take, because as Shauna alluded to there, just because it was level 5 didn't necessarily mean we weren't allowed to carry on. So yeah, there was a lot of keeping track and communication.
Great, yeah, and I just see here in the chat there's a question here about asking when the study results will be available. So thank you, Imelda, for answering that. Do you want to speak to us a little bit about the paper that you had published? I can see you've mentioned that in the reply.
Yes, we've published a paper on the development of the video, and Sinead led on that. So it's Pembroke et al. And we have a second paper that's in draft at the moment on the production of the question prompt list. And we will have other papers resulting from the actual results of the trial and the process evaluation. So a few more papers to come.
Great, great. And the questions are coming in thick and fast now, so this is brilliant. I'm glad everybody enjoyed it as much as I did. Roisin is asking, what's the feeling around communication via WhatsApp or email between clinic visits? So I think, Sinead, you've possibly answered that somewhat, and I can see that there are some other comments coming in the chat about how people are running their clinics throughout the country. So
yeah, I'll just say, Mary, that I think Sinead made a good point there, that it would be a retrograde step if it were to move to a lot of virtual consultations. You know, if clinics have to move to a blend, but those virtual ones are always with the parents, then all this effort to try and promote the engagement of the adolescent is kind of lost a bit, because they're not being seen face to face. Or if they're seen face to face, it's not very often. So that would be a big problem if the virtual is only involving the parents.
Yeah, absolutely. It really has to be a very balanced approach, doesn't it? And try and match the individual child's requirement then as well, being cognizant of their level of control and everything else. So.
And you could have adolescents who are reluctant to come to clinic, and they're just as reluctant to come to the phone or to the iPad. So, I mean, there's less opportunity to actually make them engage then, you know, because a doctor or nurse can't say, where is such and such? Can you make sure he's here? You know? So,
Great, thank you. There's another question here from Siobhan, who's wondering, has the research been considered in other disciplines for children with other chronic conditions? So could we adopt this across chronic conditions?
I think it could. Thank you, Siobhan, for that question, because we're mirroring a study that was done in the United States with Betsy, a colleague of mine, Professor Betsy Sleeth, and they did it with children with asthma. And it showed that it had an effect, it had a statistical significant effect on their engagement and communication. So it has been trialed in children with asthma, and it could be done with children with any chronic condition, because the research shows that children with chronic conditions, as they approach adolescence, they because of puberty and this disengagement generally with not wanting to be seen as a person that's ill, wanting to be normal. So they tend to start to not be as adherent to their treatment as they were before. But we think there's, and Sinead would probably agree with me on this, but we think with children with diabetes, it's even more evident there. Like, they really find it very difficult. And the research shows that their blood glucose levels are not great when they reach adolescence, and they do tend to decline, and they do tend to disengage.
Yeah, absolutely. We just got a comment here as well from Roisin, following up on the earlier question she had as the parent of an adolescent she'd love if virtual appointments followed a protocol. So she's mentioned here about the internet access and the fact that 90 to 99% of households have internet access. But it's not just that. I think certainly from my experience, the internet access, it's actually using the technology, the comfort with using that technology, and the interaction and engagement with that technology on both sides of the communication within clinics that we need to work on. So when we're developing protocols, I think that's really important to understand that it's not just the technical aspects, it's also how we engage, how we use the technology to actually make that clinic consultation meaningful.
I agree, and I think that you know, the issue about internet access, most people, households do have it, but sometimes it's very slow, and we found that to our because we've had to do so much online that often it breaks down, it cuts out, and you know, if you're in the middle of a consultation and you have difficulty reconnecting, and also you know, if there's a big push to do. Like a couple of the papers that have been published recently in this area have been saying we could easily move to all virtual, but what they're not considering is the resources in many other countries where children don't have those facilities or resources. So it's not for everybody.
Yeah, it's part of the solution. It can't be the entire solution. I think that's the key thing when it comes to making virtual augment our services rather than supersede anything that we're already doing. That personal touch will always be needed.
The personal touch,
engaging with the adolescents and getting them to speak to you and getting them to be empowering them to be part of the consultation really is.
Just to add, if I could add as well, just that awkwardness that Imelda was talking about, if there are difficulties with the internet, etc., can actually have an impact on the communication and make things awkward. So if you're talking about something quite serious, it can actually impact on the adolescent's ability to talk about that. It might stop them, you know, suddenly the internet pauses, you know, and you're talking about, because there's a lot of psychosocial issues, you know, psychological issues associated, anxiety, etc. And that can actually impact in the virtual as well if there are internet difficulties, etc. And just as well, I think it's really important, and I've heard it anecdotally from healthcare professionals, to have that face-to-face contact, because it's actually to see for them, for the healthcare professionals to see physically, especially with adolescents with type 1 diabetes, how they're getting on. That's how they can measure best, because otherwise it said it can hide sometimes some problems.
That's a very good point, because the children did report, didn't they, that they had a very good relationships with the nurses, because they spend a lot of time talking to them about different things and kind of seeing them, you know, their hobbies and different things like that. So if you had remote consultation where the nurse was not involved in it at all, then you're losing a quite a valuable aspect of this clinic, where you know, nurses tend to lead in this area, and so that would be a concern if it's not a multidisciplinary healthcare interaction virtually. And I don't think it could ever replace face-to-face. Did you want to come in there, Shauna?
No, I think actually, well, I might have seen a question there around keeping contact in between visits over the phone. And I'm not sure, I think someone mentioned WhatsApp. I don't think they would keep in contact over WhatsApp, but I have heard just through transcribing the consultations that the young people and their caregivers would link in with the nurses. So the consultants will constantly refer to, oh, well, link in with the girls about that and, you know, give us a call. So I do think that is something that does go on and is really appreciated by the young person and their parent.
Absolutely.
Yeah.
I see that somebody, Sinead Malloy, has just said the adolescent can log in from school with their phone to a virtual clinic, and parents from home or work can all be present on the video call. And that's a really good point, because more and more there tends to be agreement in the literature and research and in people who work in this area, diabetes, is that diabetes care should be delivered from the primary care sector, not from the hospital care sector, and that there should be much more coordination between the school and primary care in the management of diabetes, because it's a lifelong condition, and rather than bringing them back to a clinic in a hospital.
Yeah, absolutely. Absolutely. Well, great. Thanks so much for all of your questions, and thanks for all the wonderful information. And we really enjoyed this afternoon. I'd like to remind everybody that this is the second in our series of seminars throughout the year from the Child Research Strand here in the School of Nursing Midwifery in Trinity. So we'd love to, if you could join us again for our third seminar, which will be on the 19th of May between 1 and 2. So it's a lunchtime session again, and that's with our good friend and colleague, Dr. Coleman Noctor. So he'll be presenting on supporting parents to understand children's behaviour. So we'll be sending out the links for that for you to register and attend. So you'll get those shortly. And we've also popped the link for today's seminar, the evaluation survey. It'll take you about 1 minute. It's in the chat. So if you could take the time to do that, we'd really appreciate it. We hope you've enjoyed this afternoon and that you've had a good lunch and you've learned some new things today. Thanks to all the presenters, really enjoyed it. So I'm going to take our leave and say thank you very much and stay safe.
Thank you very much, Mary.
Thank you.
Bye.
Bye.